Hi, my name is Joe Williams. I'm Senior News Editor for U.S. News and World Report, and welcome to this edition of The Racial Divide. When the coronavirus pandemic swept into the U.S. from China, it revealed the best in humanity. Doctors and nurses working around the clock to heal and comfort the sick, competing scientists and pharmacy companies working together to conjure a vaccine in record time. But the pandemic also revealed the uglier side of human nature, including a presidential administration dubbing it the Chinese virus. On cue, racists and the unhinged linked the deadly contagion with people with Asian features, whether they were Chinese, Japanese, Korean, or American. Assaults against Asians, already an invisible scourge, spiked. Children were bullied in school, adults were attacked on city streets, a spate of elderly people, particularly women, beaten in broad daylight. However, much like the pandemic shined a spotlight on health disparities between African Americans and whites, the attacks on Asians revealed a similar problem hiding in plain sight. Consider, about 20% of Asian Americans suffer from diabetes, and an estimated 32% of Asian Americans are pre-diabetic. Cancer is the #1 killer of Asian Americans, and heart disease is close behind. Compared to whites, the Asian community has a higher rate of chronic diseases like hypertension, and although they are 5% of the US population, they account for more than half of all the chronic hepatitis B cases in the United States. Asian Americans can face bigotry at the doctor's office just like African Americans can, including language barriers and cultural assumptions that can keep them from getting appropriate treatment. And like African Americans, when a policeman killed George Floyd, Asian Americans were angered and heartbroken when a gunman in Atlanta killed 5 people in a shooting spree, a horrific act of racist violence that seemed to explicitly target their community. Clearly, there's a lot to unpack here. Fortunately, we have a great guest this half hour, Dr. Lily Higgins, Chief Medical Officer for Medicaid and AmeriHealth Caritas in Southeast Pennsylvania, a major healthcare system in the Mid-Atlantic. She's a trained family physician and has taken special interest in bringing equity to Asian Americans in the healthcare system. Dr. Higgins, thanks for joining us. Did I get everything right in that introduction?
So, Joe, just want to make sure that you're aware that I am a pediatrician, and yes, and AmeriHealth Caritas is the health plan.
Excellent, excellent. That's good to know. Well, thanks for joining us this afternoon. And I wanted to know, first off, whether or not you can give us your overview of the situation, if you can help us start to unpack things here. Give us the overview of Asian Americans and their contact in the healthcare system and how things have been going during the pandemic.
Well, I want to point out Asian American Pacific Islander, that is a vast group of people. We're talking about over 50 ethnic groups that identify as being in the AAPI. So there are many languages spoken, many cultural differences in the AAPI community. And one of the things I want to point out is that many times Asian Americans are identified as the minority that, the chosen minority or the minority that do not need help. And I really want to recognize that this is a big group. We are, there are many groups in there that have a high rate of poverty. So I want to make sure that we recognize that AAPI is a vast group of people.
Right, it's a diaspora, basically. And you've got people all across the spectrum. And one of the things that I've noticed recently in some of my research is that AAPI people tend to get stereotyped. Tell us about that.
Yes, I want to also point out the fact that we are considered the model minority. I'm going to talk about that myth, right? Mm-hmm. And I think that causes problems among the racial groups. Mm-hmm. That, and it's very harmful and dangerous to start.
Now, describe model minority for our viewers. Give us an example of what you're talking about.
So, for example, as the model minority, this is the myth. I'm going to just say this is the myth that we do not need help. We are educated. We have a higher income, and that it really kind of signal to the AAPI group that we should not be asking for help.
Hmm. Hmm. And that the community is high achieving, that everybody's affluent, everybody does better in school, that sort of thing, right?
Yes, that's the myth.
Hmm. Now, tell us what's harmful about that myth. Why is it destructive, and why do you say that it makes people assume that you don't need help?
So because the general assumption is that we're doing well, why do you need help from others? And I think it also pit against other minority groups.
Mhm.
So why are the other minority groups not striving and working as well as the Asian minority? What
Right.
is wrong with the other minorities? So that myth is dangerous, and I think it causes problems among the racial minorities.
Mhm. And in combating that myth, you're describing the fact that in a diaspora, not only are people, people have different social traditions, people have different languages, people also have different experiences in the United States, and that not everybody is doing well. You have some people in the AAPI community that are struggling with poverty, isn't that correct?
That's true. There are, for example, we know from data from national poverty rate that 35% of Burmese Americans live in poverty. So that is not being recognized when you're looking at overall the AAPI group.
Right. And so those kind of, things the record needs to be set straight on those things. But let's drill down specifically in terms of healthcare. In recognizing that the community is a diaspora, and that B, there are problems not only with poverty but with chronic health issues. Not everybody who quote unquote looks Asian in healthcare is a Chinese speaker from China and understands those language barriers. Talk to us about that and why that's important.
So yes, culturally and language-wise, there's such diversity. So one of the things that we recognize in our health plan is the need to offer language translation. So what we're seeing right now, what the rising language that we're supporting is actually Vietnamese. A lot of our speakers are Vietnamese speakers, and they need translation. So that's one of the rising languages. And also even among the Chinese speakers, there's different dialects that we are providing translations for. So when you ask a Chinese member, you can't just say they need a Chinese translator. You need to explain, you need to say, is it a Mandarin speaker that you need, or do you need a Cantonese speaker? Even among the same ethnic group, you need to identify the dialect that require the translation.
Right. And there's also the assumption that someone who quote unquote looks Asian is either an immigrant or isn't from here. Talk about that and how that causes problems in the examining room.
So yeah, so one of the things that we noted is that you need time to really during that visit. So let's say a normal visit in an office, usually 15 minutes. You really need that more time than that, especially when you need that translation service to really understand and educate the members, especially if they don't speak the language that the provider speaks, right? So we're very proud that we offer language translation for our membership, but really that provider and the office need to spend that time in providing that education and language to our members.
Right.
So one of the things, go ahead, I'm sorry.
After you.
So one of the things that we noted was that when our members are getting visits, they are getting visits. However, the quality of visits decrease, meaning the education that's being provided to the members are not the same for our Asian population due to the language barrier.
Really? And so how are the visits different?
So some of the things that we look at is, or nutritional education being provided, is physical activity education being provided. And what we noted was that during these visits, those type of educations are not being provided due to the language barrier. Even though the visit is being provided, the quality of the visits may not be the same.
Mm-hmm. And things can get lost in translation, can't they?
Yes, yes. And that's why some of the things that we have done in our practices, because of health literacy and language barrier, some of the things that we offer that's very unique is, for example, patients with asthma. We know that there is health literacy issue in understanding how to use an inhaler for asthma control. So what we did was we developed a program where we allow the providers to dispense the inhalers at the point of service. Recognizing this health literacy issue and language issue, the provider can then show the members how to use the inhalers directly at the point of service at the office.
As opposed to having them pick it up at the pharmacy and just getting it home and trying to figure it out.
Correct. And then also another thing is many a time with the asthma, there are two different inhalers that you give out. There's something called a rescue inhaler and a control inhaler. So a lot of times docs are writing for two inhalers. And our members, especially our members with literacy or language issue, can't really understand the label to understand which one is the rescue inhaler, which one is the controller inhaler. So what we did for our providers was, besides giving out the inhalers, we actually gave them a label. So we gave them a little red dot to put on the inhaler. So the red dot means for rescue. The green dot label would mean for control, the control inhaler.
It just seems so simple. It seems like a no-brainer.
Yes, but that's very unique. Our health plans were able to do that because we recognize the issue of health literacy and language as being a barrier for healthcare of our members.
Right, and so such a simple solution can make a big difference, right? Mm-hmm. Now, talk to me a little, we're gonna focus a little bit more on the language aspect here, because one of the phenomena that I also was reading up about is the fact that oftentimes if you do have an elderly person coming in for services or someone who is recently immigrated to this country, oftentimes they'll have somebody else with them, a lot of times a child or some other member of the family. Talk about what gets in the way there. I mean, it seems like it's an easy or simple enough solution, but that can cause problems as well, right?
Yes, we prefer that they have a true translator. And again, I've been that child for my family, for my parents, where I was the translator.
Talk about that experience. Talk about that experience. Was that pressure for you? Was that really uncomfortable? Tell me how that was.
Well, I remember one time my dad had to have surgery for his prostate. And I had to explain to him that maybe after the procedure, he may not be able to perform.
And your dad your dad speaks English or was challenged in English?
He does not speak any English at all. So I was the child translator for my dad.
And you had to go there with your father? Oh my goodness.
I did not. So that was the issue, as having a family translator. I did not explain to my father that he might have problem performing after the procedure. So I never explained that to my father. I just could not go there.
You got somebody else to go there for you.
Yeah, so that's why it's really important that's why our company offered translation services. We recognize that, having a child or having a member translating is not the best option for a family. And, being a child translator and knowing that I did not translate everything to my dad for that procedure, and I still don't know if he has that problem.
No. Well, and God bless you for at least doing what you did. I mean, but that's got to be very difficult. I mean, I would presume that you had to get out of school, you had to, drop whatever you were doing to go to the doctors with your parent.
Yeah, so that's why we really, why we offer the translation service. We recognize that we want to make sure we support our providers so that, we really recognize the need to make sure our providers are diverse, that we have providers that can look and speak like our members. But, Joe, that may not be possible all the time. So what we do is really encourage our providers to have people that look and understand the culture in their office. Mm-hmm. So for example, in our, Philadelphia, Chinatown, we have a provider who is a maternal fetal medicine specialist. She is definitely not Chinese. She is a white Jewish woman, but loved the community. So what she did was she hired her office managers, translators in her Chinatown office that look and speak the language. And what she also did was not just have the Chinese language, make sure that it's Cantonese, Mandarin, as well as other Asian languages. So she hired her staff in the community so that they could speak for her and make sure that she understands the culture.
Well, and that's, you point to something very interesting there, because she was very intentional about making sure that that happened. I mean, a lot of times in other healthcare systems or in other doctors' offices, it's kind of catch as catch can. Maybe they have a translator, maybe they don't. But having that kind of intentionality, that's kind of what you're underscoring here.
Yes, yes. We really encourage our providers to do that. Mm-hmm. Make sure that you have, you work within the community, you work with our members, make sure that you have the staffing to support the need of that community for your membership.
Now, I want to broaden the lens a little bit and talk a little bit about what I mentioned in my introduction, and that is some of the chronic conditions that occur in the AAPI community that we don't necessarily think of or haven't really thought of, in part because we do consider the myth of the model minority. Talk about what kind of things you see that are endemic to the community that you're helping them work on.
So some of the things that we recognize with my behavioral health colleague is that during the pandemic, especially with that quote unquote virus that was called the Chinese virus, that was very damaging to the Asian community. They were facing a lot of, trauma in the sense that, name calling. And I actually faced that myself, where
really?
I was called names and I was told to go back to my country.
Was this on the street, or this wasn't in Plymouth? You were out in the city, correct?
I was out in the city just walking around, and and I was called names and told to return back to my country. So I'm sure many of the Asians have faced that issue. So basically, I call that trauma, mental trauma. And so what I reached out to my behavioral health colleagues, and what he shared with me was during the pandemic, there was less decrease in behavioral health services, but especially with the Asian American community in Philadelphia. He was seeing less reach out for services, especially, and I was very concerned about that. So what we're doing right now is making sure in the practices in Philadelphia with a high volume of Asian American, AAPI community, we are making sure that we're providing education and making sure that our providers are referring our members for behavioral health services.
Mm-hmm. And so I imagine that pretty much left you shaken. I mean, I certainly understand that feeling, having gone through something similar, not related to the pandemic, but it has to take its toll over time. I mean, there have been studies shown that, just the experience of navigating racism for African Americans every day is a stressor that can lead to poor health outcomes. I would imagine it's similar in the AAPI community.
Yes, so there's been a lot of things that we are doing right now in the community for our membership. I actually remember one of my really good friends who is a financial person who actually went up to me and said, she was scared. She lived in the city and she, worked in the city, obviously, and she came up to a bunch of mail that was calling her name, and she felt threatened, like she felt they were gonna hit her. She was really nervous. And so she wanted some kind of training. She wanted a self-defense training. So we reached out to the community, and we actually was, the community was able to provide, self-defense training recently.
Self-defense course.
Yes. Mm-hmm.
And when you're referring to community, you mean the Asian community or the community writ large?
Asian community was able to come up with self-defense training.
Now, I want to touch on, oh, sorry, go ahead.
No, go ahead, Joe.
Well, I was going to say, I wanted to touch on another point that you brought up, and that is the fact that requests for behavioral health services went down during the pandemic. Why do you think that is?
Well, traditionally, culturally, the Asian, we have to say broadly, the Asian community tend not to, there's a stigma with behavioral health services. And I think that stigma is stronger in the Asian culture and the Asian community culture. So we need to provide more education and reach out to those members that, it's fine. You need, just like physical health services, you need to reach out for behavioral health services too.
Yeah, there's a strong stigma about that in the African American community that we're just now starting to get over. But in times like these, it's got to be critical, mainly because you have people on lockdown, you have people who are under threat, basically, in addition to the lockdown, not to mention having to care for seniors, having to care for children. That's got to be a huge stressor that needs these kinds of services.
Mm-hmm.
And so what does your outreach look like? How are you getting to people and informing them of these services, that they're not only available, but that they contribute to overall health?
So one of the things we want to make sure of is the education to our providers and making sure that they're aware that to screen for depression, screen for anxiety, and then referring them for behavioral health services. So we're doing, what we're working on with my behavioral health folks is doing that education piece to our providers. And of course, making sure our members are aware of those services that are available.
Now, does that mean like brochures in a community center? Does it mean going to markets? How does that outreach get to people?
All the above. Making sure that they're aware of the services and really just eliminate that stigma of getting behavioral health services.
Mm-hmm. And again, when we talk about trauma, I mean, you mentioned trauma a few minutes ago. I understand, the Black community, I mean, speaking from personal experience, George Floyd was incredibly traumatic, and it brought this pall down, especially during the middle of the pandemic, that really was just heavy. And I kind of want to know if the experience was similar when we had the shootings in Atlanta earlier this year. Was there similar kind of expression of trauma in the community, and how did that express itself?
Oh yes, definitely. I mean, the community feel fear. There are many attacks even near the convention center, and that's right near Philadelphia, Chinatown. So there's a fear about walking out. So one of the things that the community is doing is that they're going to have watch groups, with whistles and making sure, and they're watching out for each other. So that's something that's being set up within the Philadelphia Chinatown right now.
Mm-hmm. And do you think that this sort of well, there are two things. I mean, I wonder, if this sort of trauma is something that a lot of people didn't realize was going on and didn't know about until this pandemic and until the shooting happened, and B, is that part of the whole model myth, model minority myth and stereotype that we spoke about earlier?
Joe, you got it right. I mean, it's the fact that we feel that we can't speak up because we are, quote unquote, the model minority. We are not supposed to reach out for help. And, facing discrimination, facing people calling me names, I experienced that even before the pandemic, but obviously it has increased because people feel they could do that now. They
Right.
feel like they were given the right to do it.
Mm-hmm.
I remember as a child going to, and I remember this so blatantly, is I was on a beach, and just enjoying myself, and this grown man came up to me and called me, in Asian slang, and then spit at me. I was like, this is a grown man that did that to me. Yes.
Oh my God.
And I remember that. I still remember that as a 50-something-year-old woman. And then I have occasional incidents where I'll cross the street and people just call out, a name, and I just ignore that. But I'm facing it more now because I think people feel that they have the right to do it.
And when I say that, I mean, that's an incredible example of what I'm talking about. And I feel for you in that we don't hear about that very much in the news. We don't hear about discrimination against Asian Americans. We don't hear about that kind of bigotry. And it always seemed like it was just on the down low, that it was something that happened that nobody heard about, that nobody complained about, and that we didn't really embrace as something that we needed to fix. But now that we're in the middle of a pandemic, and now that we're, I guess, at the tail end of the pandemic, depending on how you look at it, and now these things are starting to come out, the disparities between whites and Asians in terms of health, the hypertension, heart disease, cancer, in addition to bigotry. So there has to be some element of that where you're like, well, all of these things are interrelated. I mean, we have a very serious problem here that we need to address.
Oh, I agree. I agree. So I think and that's why our company recognized that. And that's why we make sure that we have providers that look and can speak the language. If they cannot do that, we support them in making sure that they have office staff that could do that. We provide language services. We try to make sure that, we expand our health, make sure they have some initiative to help, expand the health literacy. I love this program. This program is for our diverse membership. It's called Family Food, where we recognize that a lot of our members really do not know how to go shopping and buy the best food, produce, and actually know how to cook. So what we do is recognizing food insecurity. We target those members, and we would actually encourage our certified dietitian go to the home, see what kind of food that they have in the pantry, if they have refrigeration, if they have a stovetop, if they have an oven, and then go shopping with them where they shop. So it may not be the Acme or the ShopRite. It may be that corner store where there's limited, produce, limited, things that you could buy, but they would go shopping with them where they shop and then bring back the material to their home and teach them how to cook that produce, the dairy or the meat that they got from the corner store, to make sure that they could expand their SNAP benefit and make sure that they're eating appropriately.
Right, and that's right in your wheelhouse, because I noticed as part of your background, you're a trained nutritionist. You've dealt and you've worked in programs to alleviate hunger. That's a big deal as far as health is concerned, isn't it?
Yes, that's really important. I mean, we say food is medicine, and that is true.
Mm-hmm. And that goes across the spectrum, not just with the AAPI diaspora, but with everyone.
Mm-hmm. And since we're talking about AAPI, for our AAPI members that have food insecurity, to go with them, to go grocery shopping with them at their corner store, it might be the bok choy, the maybe whatever what they're used to, and then bring it back home to cook with them.
Mm-hmm. And that's a program that's run out of your particular healthcare organization. Is that correct?
Yeah, I'm quite proud of it. I don't think there's other health plans that are currently doing that, and that's a benefit for all our membership.
Mm-hmm. And so, in addition to poverty and chronic diseases and discrimination, there are a lot of challenges. There are a lot of pressures on the community. How do you deal with that? Is it a matter of behavioral health? How do you personally deal with that?
I'm very much involved with the community. I'm in the Asian Women Coalition, and we try to be, support the community. So one of the things
you're getting support in that organization as well, I would imagine.
Yes. So I want to mention something about, you mentioned food, you mentioned, I also want to mention about housing. What we recognize, traditionally the AAPI community tend to have housing that tend to have many members that live in a household.
Multi-generational, yeah.
Multi-generational. And right now, what we recognize in Philadelphia during the pandemic, there is, that's going to end of this month, is the eviction moratorium. So one of the things that we're doing right now in support of our members to make sure that they are getting all the services that they need and get rental assistance from the state is that we actually partner with a medical legal partnership in Philadelphia to help our members that are facing eviction or having any issues with rent and getting rental assistance, that we are contracted with a legal partnership to help them in getting that, not making sure that they don't get evicted from their housing.
Right, because housing is an important component of health as well, right? You can't be stable in your health if you're unstable in your living conditions.
Correct.
Mm-hmm. So we're about out of time, Lily, and I could talk with you for another 45 minutes, certainly, but I'd like to end on a positive note. Tell me something good. You mentioned all these programs that your healthcare system is involved in. Do you see things as looking up? Do you think people are finally starting to get the message that the AAPI community is not a monolith, it's a diaspora, and that they have challenges as well that need kind of uplift? I mean, would you say that that's happening now in terms of the community?
Yeah, and I think, Joe, I want to first of all, thank you for this opportunity, because we know that in May was the Asian Heritage Month. And, I support, thank you for supporting this conversation, because it's, almost July and we're still having this conversation. And I think that's important to continue this conversation, to not have this Asian minority myth that we don't need help, and to really voice what's happening in the community. And, and thank you for the opportunity to voice something that I experienced when I was a child that I actually probably didn't share with my husband. It's, something that it's hurtful, but I still remember it. But this gives us an opportunity to talk about it and not be afraid to ask for help. And I think that's important.
Well, I couldn't agree more, and I thank you for sharing that. It was really powerful, and I appreciate it deeply. And with that, we've come to a close. I'd like to thank our guest, Dr. Lily Higgins, and I appreciate you coming to talk with us. Hopefully, we can get you back on again soon, and we can go even further and talk about more things that are on your plate and things that you're doing.
All right, thank you, Joe.
Take care. Well, thank you very much for joining us on The Racial Divide. My name's Joe Williams, and I'll see you next time.